Hello, everyone. Thank you for joining us for today's PDS discussion on navigating the 2026 legislative updates. My name is Nicholas Rodrigues. I'm the National Sales Manager at PDS, and today I'll be playing the part of moderator. I'm pleased to have joining me Scott Everitt.
Thanks, Nick, and good to be here to discuss some of the things that are coming down the pike and some things that we probably need to be a little bit prepared for.
Perfect. And Scott, so let's jump right into it. What are we looking into today?
Yeah, Nick. So what we're going to talk about today are some changes that have been coming down with both the One Big Beautiful Bill Act as well as the proposed Medicare fee schedule that came out from CMS, and some things that we're looking at there and really kind of tracking. With the One Big Beautiful Bill Act, one of the big things is going to be health coverage eligibility, both for Medicaid recipients as well as folks who are on Affordable Care Act plans. When we're looking at the CMS proposed fee schedule, there is a conversion factor increase, but there's some changes to the RVUs that are coming as well. And of course, with the One Big Beautiful Bill Act coming through, and it's projected to increase the deficit a little bit, and that automatically triggers PAYGO without a congressional waiver. And so that could trigger things like sequestration and things like that. So we're going to discuss some of the things that are out there.
Okay. So, Scott, I've heard a lot about the One Big Beautiful Bill Act. Why don't we start there? And how's that going to impact healthcare organizations?
Yeah, obviously there's a lot that went into that act, and not all of it is healthcare related at all, but there are a few significant things that really did hit that when that came through. The big one is that they built in a 2.5% increase to the Medicare physician fee schedule, which was taken last year as part of a budget reconciliation piece. So they put that back in, which is a good thing for physicians. So we're going to talk a little bit more about how that may be mitigated by some other changes that are out there by the proposed rule. The big thing that we're talking about with this are changes to Medicaid eligibility and the expiration of some of the tax subsidies for folks who have those Affordable Care Act plans. And so when we're looking at that, those are the things that maybe you're hearing about a lot now with the government shutdown. And those are some of the things that Democrats are really trying to push to not have those come to pass. One of the other things that's in there that really could impact medical groups is they place some limits on loans and grants for postgraduate education, which could affect folks in medical school, could affect folks going to physician assistant school, nursing school, things like that as well. And so that could definitely have an impact on healthcare as well.
So I know we just kind of touched on a little bit about this, but how does this specifically going to impact medical groups, Scott?
I think the big thing that people need to be prepared for is an increase in unfunded care. There's going to be people coming into our hospitals, emergency rooms, practices who no longer have insurance. They may not even know they don't have insurance. And that's going to be something that we need to understand and that we need to be prepared to work to try to mitigate as much as possible. If we're a practice, they've changed some of the requirements for Medicaid where they have to re-verify eligibility for Medicaid every 6 months. And
Hmm.
so if I'm a practice, I need to start doing more frequent insurance coverage verification, that it's no longer enough to just check the patient once a year or however often we do it. We need to make sure we're doing a really good job in verifying insurance coverage that are out there. And then, of course, with the changes that are coming in student loans and the ability for people to afford postgraduate education, we may be looking at provider shortages and starting to understand what's that going to mean for our practice, that we need to really make sure that our physicians and our providers are really, really engaged so that we can retain those, because it may be more difficult to recruit in the future.
Yeah, I could see physician retainment being a big focus. A lot of groups, I know it
Mm.
already is, with what we've seen in the last few years, but I can see
Yeah,
that,
absolutely.
exacerbating quite a bit there. So, okay.
Yeah.
So, we also know that the CMS released the 2026 proposed fee schedules. What are we seeing there, Scott?
So right now, and I want to emphasize right now that this is the proposed fee schedule. They just
Hmm.
got done with the public comment period, and I know that a lot of physician lobbying groups and things like that really submitted a whole lot of public comments on this fee schedule, because there are some things that can really hit medical groups if they go through. The good thing is that it had that increase in the RVU conversion factor. But what's interesting is that they've actually proposed this year a dual conversion factor. So it's going to jump up to 3359 for those practices that are qualified for the advanced payment model. But for those who aren't, then it's only going to be a 3342 conversion factor. I know it seems like a 17-cent difference isn't a huge thing, but it's something that you need to keep in mind and understand. If you have a large volume, it may be worth it to start looking at what do we need to do in order to become a qualifying participant there. While this 2.5% increase did come into play, one of the things that they are doing is they're kind of retooling the work and practice expense RVUs for some services that are out there. I don't expect this is going to be as big as it was in 2001, where they totally redid the E&M codes, but this is one that they are looking at about a 2.5% decrease in work RVU for certain time-based services. And so if you're a specialty service, you're going to want to get a handle on, what are those services where that decrease is coming through. And then, of course, there's a reduction of sometimes up to about 7% in certain indirect practice expense RVUs for providers who are working in facilities. So understanding your practice patterns in terms of facility versus non-facility RVUs, and that practice expense could impact the reimbursement that you're getting from Medicare when they are working in facilities.
So a lot going on, and I got to say the dual conversion factor, sounds a bit complex there. How do we see this playing out, or what do you think the impact will be to groups?
Yeah. So again, if you're a specialty practice, or if you do a lot of non-time-based procedures, you really want to get a handle on what are those procedures where that work RVU is dropping. You want to understand where you may see impacts in your practice expense RVUs that are coming through for your physicians who may be working in facility-based clinics. That differential and conversion factor that you talked about, Nick, 17 cents doesn't seem like a lot, but if you take your total Medicare RVUs and multiply it by 0.17, you may see that it may be worth it. There may be an ROI in trying to become qualifying partner for the advanced payment model. So just kind of looking at that as a practice and seeing if this is going to make a significant difference for you. Again, looking at facility versus non-facility, how are you practicing? What are the clinics listed as? And then, like I said, this is proposed. This is only what's out there. It's not the final rule yet. In fact, we're going to do another one of these in January where we'll go over the final rule. But for this one, I think the big key, look closely at the changes that are out there and then really model the impact on what you think is going to happen with your budgets.
Yeah, that's a good point, Scott. And I've seen a lot of organizations we work with doing that very thing you just mentioned. They're taking, a look at their current reimbursement maybe for this year, and they're modeling out, what would that look like if proposed rules were to come into play against their current utilization. So they're kind of trying to understand, here's where we are today. If these rules were to go in effect, how do we fare, right?
Right. And so, understanding, especially if you're a multi-specialty, there are going to be departments that are winners and departments that are
Right.
losers that are coming through on this fee schedule. What's really important is to be able to kind of communicate that out and plan for it, especially as you're putting together budgets or you're trying to project, forecasted revenues for the coming year. Really looking at the different services, looking at how it'll impact you in terms of what your projected and budgeted RVUs are going to be is really kind of a key to being able to understand that.
Yep, absolutely. So I've also heard there's been quite a few changes to MIPS and shared savings. Is that true?
Yeah, I mean, the MIPS haven't had a lot of changes. They decreased some of the quality metrics that physicians are required to report on and things like that. So they reduced those number of metrics. They've actually increased the number of value pathways that are out there in certain specialties. But really, MIPS kind of remained pretty status quo. The Medicare Shared Savings Program, the new emphasis from CMS now is for those who are on the basic program is they really want to start migrating those practices to the enhanced model, which what
Okay.
that does is it does cause practices to take on a little bit more risk in this shared savings piece. And so just understanding what that means in terms of where it's out there. what it also has done is it's reduced the threshold for the number of assigned beneficiaries you need in order to be considered an ACO. So you no longer need that 50,000 assigned beneficiaries. There's a lower threshold for that. So that's something that can help out a lot of groups that are looking to become ACOs who are ACOs, but kind of at that threshold limit and a little concerned about it.
Right. Definitely something that groups should be looking into if they are in those types of programs. Okay. So if you've attended PDS discussions in the past, we always like to interject some quotes. And while looking for a good quote to fit this discussion today, we came up with this one, right? Forewarned, forearmed, to be prepared is half the victory. And what we're really talking about here is the more we can prepare as groups, as these changes come into effect, the better off we'll be when they do come into effect. So doing things like we shared earlier, modeling your data against maybe your current utilization, trying to understand, what groups or what, subdivisions will come out ahead, or, we might need to implement changes in to stay effective there, right? So
Yeah, and so I agree with you, Nick. I think really being prepared and looking ahead so that we're not caught off guard by these changes that are coming through, that we can make sure that we're kind of ahead of the curve and that we're doing the right things right away, in order to make sure that we're being financially responsible in the coming year. So for those of you who may have any questions or anything like that, please feel free to contact us at solutions@pds-online.com. Like I said, we'll be doing another one of these after the final CMS rule comes out to clarify things as much as we can where it comes through. Hopefully you'll join us for that as well. And if there's anything PDS can do to help you or your practice with the modeling of these changes, please feel free to reach out to us. We'd love to have a conversation with you.
thank you so much, everyone. Have a great day.